Do I press got it or not?
Yep. So we have started. So hi, everyone. Thank you so much for joining our seminar today with Professor Lawrence Kohan. So Professor Lawrence Kohan is an experienced orthopaedic surgeon specializing in joint replacement and reconstruction procedures of the hip and knee. He utilizes the latest minimally invasive techniques in hip and knee surgery. He routinely performs anterior minimally invasive surgery for total hip replacement procedures, is actively involved in training and education, and is committed to ongoing medical research in order to facilitate the best recovery and outcome for his patients following surgery. Professor Kohan was one of the pioneers in minimally invasive hip surgery in Australia around more than 15 years ago, and now has one of the longest series of patients standing at more than 1,400 anterior hip procedures performed to date. It is our absolute pleasure to have him on our panel, and I'll pass it on to you, Professor Kohan. I'm just going to stop sharing now. Yep.
Thanks. Press share screen. Okay. Do I press share screen? Or...
Yep. Yeah, you can press share screen now. Yep.
Or if I get the presentation up, no. Share. Okay. Okay. Does that look all right? Is that coming up okay?
Yep, that's all good. Yep, I can see the first cover.
Okay, hello everyone. Happy Friday, and thanks for devoting a little bit of Friday to this. I'm going to talk about pain because that's one of the reasons why we embark on this type of surgery. And a lot of this work was done by my colleague and friend Dennis Kerr, Anaesthetist Supreme. Now, we are now in the third generation of joint replacements. In the first generation, which was about the 1960s, when joint replacements first started, the goal was pain relief. And if you had a limp, and if the leg was a bit short, and if occasionally dislocated, and if you needed to use a crutch or a stick, that was okay. That was okay. Then generation 2 came about, and in generation 2, it was necessary that for a successful operation to be judged as being successful, the joint needed to work, and it needed to work well. The range of movement needed to be almost what it was preoperatively, or at least when you were young. The alignment had to be within normal parameters, and you had to be stable. You basically had to return to activities of daily living, and those requirements started in about the mid-80s to late 80s. Now we're in generation 3. The requirements of generation 1 and 2 are given. In other words, pain relief must be assured. The wear of the joint must be acceptable. So when people say, well, a joint's going to wear out in 10 years, that's really no longer the case. Well, it depends what you do on it, of course. And now, certainly the hip could not dislocate and leg lengths were meant to be equal. So now, in generation 3, the requirements are that you are expected to be able to return to all the normal activities you did in your early 20s, or at least that's the expectation, and clearly that's not realistic. But in the current generation, durability is very good, surgical techniques are very good, but a return to normal function clearly is something that needs to be discussed with the patient. Anyway, we are now in generation 3. Anaesthesia progressed simultaneously. In generation 1 of anaesthesia, survival and minimization of mortality was the main thing. Now we're in generation 2, where rapid recovery and restoration of acceptable physiological parameters are the guidelines, the criteria. Now, we're talking about elective surgery now. We're not talking about trauma or tumours. So the primary aim is that the surgery must solve the patient's problem. So a good operation is the entry point and not the finishing point of this new paradigm. Now, how do we classify the success? Well, Professor Royce from Royal North Shore Hospital in Sydney defined the quality of recovery in these 6 domains: physiology, nociceptive, the residual pain, emotional, ability to manage activities of daily living, cognitive function, and the overall patient experience with the surgical process. And just briefly, physiology is the standard parameters: heart rate, breathing, ability to move, consciousness, that sort of thing. Pain relief at the time of testing, pain and nausea need to be assessed and hopefully absent. The emotional domain relates to anxiety and depression at the time of testing, and that relates to a significant extent on the drugs used for the anaesthetic. Activities of daily living: patients should be able to stand, walk, dress without assistance, and eat and drink. And finally, cognitive function, orientation, verbal, memory, basically executive function and concentration. The overall patient perspective is the summary of all those things: being able to return to normal activities, clarity of thought, ability to work, and the overall satisfaction with the process. Now, we've been working on this technique for the last 24 years. The main purpose is improving patient outcomes. Now, in brief, the technique involves blocking the pain at the site of origin, like the dentist blocks your mouth when he does whatever it is he does. If you block the pain at the site of origin, then the pain never reaches the spinal cord or the cerebral cortex, where its magnified memory is laid down and the whole unpleasant process of pain actually is generated. So there are 5 phases in this process, and we've published these results and discussed them ad nauseum. And I'm only going to talk about the first 3: preoperative, intraoperative, and postoperative care. Now, elective surgery of the type that we do is ideal for this technique, because we know when the pain is going to develop, because we're going to cause it, where it's going to develop, and how it's going to develop. And with the appropriate technique, we should be able to anticipate and to prevent it. Now, joint replacements, hips and knees, they're peripheral surgery. It's not particularly big surgery. It's not a heart transplant or a liver transplant. So in the appropriately prepared patient, there is little physiological disturbance. There should be little physiological disturbance caused by the operation itself. The other thing, of course, is that for this day and age, in the elective hip and knee replacements, the joint works immediately. So the patient could get up off the operating table and walk off. And, the mechanics of the joint will allow that. So in this scenario, if the patient is not sick before the operation, we should do everything we can to make sure they're not sick after the operation. Now, up until, say, the late 1990s, patients with this sort of surgery were sick in bed because of the high-dose morphine. They were in pain, they were confined to bed, and they were in hospital. When I was first taught to do joint replacements in the early 1980s, probably before most of you were born, patients were in hospital, in bed for 3 weeks. Then they, because the joint would not function well, and then they were sent to rehab for 6 to 12 weeks, depending on the patient parameters. Nowadays, the patients are in hospital for 1 day, 1 night. Sometimes they go home the same day, and they, again, in healthy, otherwise well patients, they can expect to get back to activities of daily living at 10 to 14 days. And that's all within the lifetime of one surgeon. So we aim to control the pain at the site of generation using a cocktail of local anaesthetic, adrenaline, steroid, and an anti-inflammatory. And again, we published this cocktail and its safety. And we use this because nerve blocks, which are very effective at controlling pain, nerve blocks block muscle. So patients can't get up and walk straight away. And we do our best to avoid narcotics because the sedation and the attempt and confusion interferes with our mobilization protocol. There's a high risk for falls, keeps patients in bed, high increased risk of DVTs and urinary infections, and a whole cascade of things that we try and avoid. So we aim to achieve this with a meticulous pain management in using primarily, as well, at least as a beginning, local infiltration analgesia, which is, it's really simple. We just have to inject with this cocktail all the areas that were operated on, retracted, pulled on, whatever was could be assessed as being the generator of pain is injected. And that takes maybe 10 minutes most. So we aim to fill the whole area with local anesthetic, and then we, for knees, we wrap it up with a gentle compression bandage to keep the local anesthetic in place. We can't do that for hips all that easily, but it's possible, like a snake bite. And then we put a little catheter at the operation site to re-inject the local anesthetic either through the night or early in the next day. Now, the long-acting local anesthetic will cause numbness for about 18 hours. And by that stage, the pain receptors in the affected area accommodate. So they're now used to the injury that was caused by the surgery and no longer send the help signals to the spinal cord and to the brain. So this cascade of pain generation is most in the early period of the recovery process. So in the event that I miss a spot with a local anesthetic and the patient wakes up in pain, then the results are never as good as those where I've been very effective with the block and there is no pain, or when they wake up. And then the block wears off after 18 hours or so, and we have a transdermal analgesic technique that I won't go into. So the aim is to prevent the pain signals to ever get to the central nervous system and to control the pain at the site of generation and not to poison the whole patient by giving high-dose narcotics, analgesics, sedatives in an effort to control what is essentially a local problem. And it relies, this is our formula. We use ropivacaine, which is a long-acting anesthetic similar to Marcaine and xylocaine. And we use ketorolac, which is an anti-inflammatory agent, similar but not, well, similar to Nurofen, but different activating technique, and adrenaline to keep the local anesthetic cocktail in the area for as long as possible. So this said, we can control the pain where it starts. We can affect the pain receptors, the nerve endings, and the chemical soup that is generated around an operation site as a result of the trauma, and that's the effect of the anti-inflammatory. Now, this is not an end in itself. It's a management technique with the aim being to be able to get the patient up and walking, which is not something that we can do with, say, narcotics like morphine. We do use morphine in a situation where either I miss a spot and patients are in pain, or for some reason, like if we operated on the knee and they got terrible spinal pain, then obviously the technique needs to be modified. But we do our best to avoid the narcotics. They're just not good for you, as I'm sure you know. So the key element is that this technique is only for the perioperative period, for the first 24, 48 hours, but it does allow us to implement a whole recovery process that would not be possible if the patients were in hospital needing patient-controlled analgesia or tied to the bed with a catheter or a drain or something like that. So people who present for arthritis generally are not sick, and we aim to avoid making them sick with our treatment. Morphine itself, I don't know if you've had it for whatever reason, but it's actually a miserable drug, and it makes people sick and disorientated. And it's important to understand that it does not eliminate pain. It eliminates the perception of pain. So someone who's on a hefty dose of morphine, if you ask them, have you got pain? They say yes. And do you care? No. And it keeps people in bed because of the disorientating effect. Epidurals, well, they're great, but they're time consuming. They do actually block the lower limb function. My anaesthetist tells me that it's the most litigated anaesthetic technique they use, but fundamentally it's incompatible with effective mobilization. And nerve blocks are very effective. They work wonderfully, but they work. So the muscles are paralyzed as well, and we have difficulty then getting patients up and out enough to allow them to be out of bed, enough to allow them to resume activities of daily living. And so we use local infiltration analgesia because it's better than the other techniques. And there's a multitude of overseas studies that have compared this technique, and yes, it's a bit tedious to use, but in terms of the 6 domains of quality of recovery, it is the winner. Patients have a clear head, they feel essentially normal, there's no muscle weakness and no sedation or nausea because they haven't had any narcotics. And it enables early mobilization and early discharge. So in summary, this is the first part of our plan to improve patient outcomes and minimize complications. But it's a critical key. So our typical patients experience low pain levels. They feel fairly normal as they recover, even 4, 6, 8 hours after the surgery. All things going well, we expect patients to get up and walk 4 hours after surgery. And we avoid the use of catheters. They're associated with infections in joint replacements. So after 4 or 6 hours, people usually need to go up and go to the loo. Avoid wound drains, transfusions, epidurals, and so we don't get their complications either. Thank you very much. Thank you for your attention.
Yep. Thank you so much, Professor Kohan. May I ask if anyone has any questions? If you do, please unmute yourself and come forward, please.
Come on, I couldn't possibly have been that clear.
Oh, good morning. My name's Lynn Johnston.
Morning.
I'd like to know what percentage of the population require replacement surgery, hip or knee replacement surgery.
Oh dear.
Is
Okay.
it most people as they age? As you know, for example, the over 70 age group.
It's not quite as simple as that. It really depends on the quality of life that you have, or that you expect of yourself. Most of the now we're just talking about arthritis. We're not talking about rheumatoid or trauma or anything like that. Just talking about degenerative arthritis, and that's not a dangerous condition. It's not going to kill you. It is just going to modify your life. If you're happy to go with the limitations, then it's absolutely fine. Now, nowadays, of course, people, as they sort of particularly move into retirement, they have the expectation of regaining mobility, regaining, quality of life, I guess. And in terms of proportion, it's steadily rising. Again, it depends. In our Caucasian society, knee replacements are more common than hips. But in terms of the proportion of the general population, I can't tell you. I can't tell you. I can tell you that the necessity for requirement of joint replacements, say knees, which are more common, started, if you look at the graph, it changed dramatically in about 1985, as I recall, just looking at the American data, and it just happened to coincide with the launch of the Big Mac.
Right.
That's actually true. It coincided, well, I don't want to be flippant, but it coincided with a dramatic increase in population obesity.
Right. Thank you, Doctor. It sounds like you've really done well with this surgery.
Well, yes. Interestingly, when we tried, my anaesthetist and I, to publish it in the early noughties, we couldn't do it. We got rejected by 7 journals, and the editors said it was a quirky and idiosyncratic technique. Okay, so we persevered. Then there's a surgeon by the name of Henrik Killert. He's Danish, and he popularized, or he developed the technique of doing inguinal hernias through a local anesthetic. Okay, so he was one of the proponents of day surgery for things other than moles and things. Now, he wrote to us to say, could he come out and see what we did? And I said, sure, absolutely. So he came and stayed for a week and watched what we did. We did 20 joint replacements. And at the end, he said, look, I thought you two, my anaesthetist and I, Dennis, he said, I thought you two were charlatans because everybody's been talking about this. And I didn't think you can do it. I haven't seen anybody do it. And I came here to prove that you lied. And he was instrumental in allowing our technique to be published. He was editor of the Acta Orthopaedica Scandinavica. And I thank Henrik. He was objective enough to assess the technique and see that it is a benefit. We've been talking about it, well, as much as we can, over the last 20 years, and it's been adopted in varying degrees around the world. Europe and Scandinavia a lot, Australia not so much. My wife says it's because of my abrasive personality, but okay, that's not for me to say. But the key element is to get the patients walking straight away.
Right. So you're saying that most orthopaedic surgeons don't use the same practice as you?
I don't know. My discussion with patients who've been elsewhere, you have to, in order for the technique to work, you have to be meticulous, okay, and you have to have a bit of patience. And if you're not meticulous in initiating the initial block, it's not going to work. And then it's easy to blame the technique rather than you're following the protocol. So certainly everybody knows about it, but whether they use it as we have published it, don't know.
Right. Thank you, Doctor. Congratulations.
Yeah.
Yep, thank you so much for that. Does anyone have any other questions that you'd like to ask Professor Kohan? Please, if you do, please unmute yourself and come forward. Yep. So it
Hi,
seems
Dr.
like,
Kohan.
oh, sorry.
Could I just ask, and this is a little outside what you were talking about, but I have a client who had a left total hip replacement, but still has ongoing pain following the hip replacement. So if I just give you a little bit of background to it, she had the hip replacement done, and the day after the hip replacement, it was found to be dislocated. And she underwent several closed reductions, which didn't work. And then within 3 weeks, she had to undergo a revision of the hip replacement. and the findings when they did the revision were that there was a loose stem and that the cup was grossly anteverted, like approximately 60 degrees. And so now she's had the revision done years later, she's still experiencing quite significant pain.
Okay, well, it's complicated.
Yeah, it's a bit complicated. So I don't mind if you don't want to answer it, that's fine. But I just was interested in listening to you this morning just to try and get an idea about, you know, why she might still have ongoing pain.
Pain after this period of time, and revision surgery is different because it's most of the revisions are an order of magnitude in complexity as opposed to a primary. And there is a problem that needs to be addressed, which complicates. I mean, it is no longer common or garden osteoarthritis that needs to be addressed. For pain to be present, let me go back a step. I say to the patients that like a joint replacement is not going to be the one you had when you were 25 years old. You might get a bit of an ache, you might swell, might click. It is, you know, we just have to understand what the thing can do for you. It is a machine we put in there. Now, to have pain after this period of time, it can be all sorts of things. Could be could be something wrong with the implant, could be scarring, could be a low-grade infection, could be chronic pain, which is now a central nervous system problem. There's an algorithm. I mean, if patients have this problem as an impediment to their quality of life that needs to be addressed, or at least need an answer, there's an algorithm to work through all the options to make sure, and sometimes more than one thing's going on. But certainly a diagnosis or a differential diagnosis should be possible, whether that can be fixed or whether she wants to go to the process of being fixed is another issue.
Yeah, okay, thank you.
Pleasure.
Sorry to give you that little curly one at the end.
That's all right. Fine.
Yep. Thank you, Sue, for that one. Does anyone else have any questions? This is your last chance to unmute yourself and ask Professor Kohan.
Or have an early Friday go to the pub.
Yep, I think it seems like we don't have any other questions, so we'll probably wrap it up now. Thank you so much, Professor Kohan, for joining us today. It was an absolute pleasure. So yeah, thank you everyone for joining, and thank you, Dr. Kohan.
Thank you. Have a good weekend.
Thank you. Have a good weekend.